Hello, I'm Howard McCollister. I'm a foregut and bariatric surgeon at the Minnesota Institute for Minimally Invasive Surgery. I want to thank SAGES for the invitation to give this presentation on management of reflux after sleeve gastrectomy. These are my disclosures. Certainly, reflux after sleeve gastrectomy is not an uncommon event, and most bariatric surgeons that do any volume of sleeve gastrectomies have seen this on more than one occasion. The problem that we have is that the data is kind of a mess. We suffer from comparing the early data to the current data, from a lack of consistency of testing and inconsistent definitions. We know that the incidence is somewhere, according to the literature, between 2% and 51%. One thing is sure, if you do sleeve gastrectomy, if you see post-sleeve patients, you are going to see patients that have post-sleeve reflux. The problem, of course, is that over the 20-year history of the sleeve gastrectomy, we have suffered from a variety of inconsistencies relative to definitions, methods of data collection, and evolving techniques and concepts. This particular diagram is going to be familiar to almost everybody here. It demonstrates the reflux barrier of the upper stomach. And of course, this particular area of the stomach is vulnerable to injury during the course of sleeve gastrectomy. The most significant component of keeping the LES functional tends to be the sling fibers and the angulation of the angle of His. Obviously, these things are at risk during sleeve gastrectomy, particularly in the event of a misplaced staple line. Basically, there are three things that are likely to contribute to post-sleeve reflux: the possibility of retained fundus, high intragastric pressures for a variety of reasons, and an impaired reflux barrier, again, for a variety of reasons. Retained fundus is a problem that usually relates to technique. It may hide previously unrecognized hiatus hernias, and it may expose the distal esophagus to higher localized pressures at the level of the acid pocket, therefore creating more problems with reflux in that particular location. Strictures and kinks and twists can occur during sleeve gastrectomy. These can result in high intragastric pressures that are capable of overcoming the pressures at the reflux barrier. And then there's impairment of the lower esophageal sphincter and the reflux barrier. This is probably the most common contributor to post-sleeve reflux. The nature of sleeve gastrectomy puts the effectiveness at the LES at risk due to the potential for disrupting the esophageal sling fibers and disrupting the angle of His. Taken in conjunction with perhaps a pre-existing LES weakness and also a hiatus hernia, then post-sleeve reflux becomes all the more likely. The data is a little confused by at least one publication that indicates higher LES pressures after sleeve gastrectomy, as opposed to most publications that demonstrate impairment of the reflux barrier due to loosening. But in many respects, I think it's reasonable to conclude that the degree of LES impairment also tends to be a technique issue and relates to the aggressiveness of the proximal staple line relative to the esophagus. Hiatus hernia also impairs the reflux barrier by displacing the angle of His and also making the whole LES subject to the lower pressures of the thoracic cavity. If you do a sleeve gastrectomy on this patient and don't identify and address the hiatus hernia intraoperatively, failure of the reflux barrier both at the hiatus and at the LES is likely to result. So you do a sleeve gastrectomy on a patient, and 6, 8, or 10 months later, he or she comes back to you complaining of reflux symptoms. What do you do next? Certainly, I think at that point, a comprehensive GERD workup is indicated. We need to find out whether or not they are indeed refluxing, what are they refluxing, and why are they refluxing. We have to make a decision to try to determine whether the reflux is due to high intragastric pressures as opposed to an incompetent reflux barrier. So likely start with an EGD. One of the things that you'll be looking for is a stricture or a kink or a twist or some anatomic abnormality in the gastric pouch itself. You're also going to want a retroflex to try to observe and determine whether or not there's some retained gastric fundus. You're going to look for Barrett's esophagus because it's unlikely that you would want to do a sleeve rescue if there was Barrett's esophagus present. There is a possibility of hiatus hernia that you have to rule out. And while you're there, it's reasonable to attach a wireless pH probe to try to determine what the actual acid exposure in the distal esophagus is. Because symptomatic post-sleeve reflux is so common, we need to be very diligent about trying to accurately diagnose it preoperatively, because if they already have reflux when you do the sleeve, that operation is likely to make it worse. I'd put in this plug for a comprehensive preoperative reflux evaluation for prospective sleeve gastrectomy patients. High-resolution manometry is an important concept in the evaluation of post-sleeve reflux. We need to be very diligent about understanding the functionality of the lower esophageal sphincter, as well as evaluate the esophageal motility. The motility of the esophageal body is important because it's going to have an influence as to what we might choose for some sort of management of this, operative management, that is, of this reflux problem. From a standpoint of treatment options, if on EGD you find a retained gastric fundus, that's going to have to be treated by reoperation with resection of the redundant fundus and probably a cruroplasty or hiatal herniorrhaphy. If you identify a stricture or a kink or a twist, dilation is an effective means of dealing with strictures. We have had good luck using a 30 millimeter achalasia balloon, and we've been intrigued by the use of the EsoFlip balloon, a component of the EndoFlip system, for use in such dilations. Otherwise, management of strictures can be done conventionally using maybe a seromyotomy or a stricturoplasty, as illustrated here. If you find a compromised reflux barrier in the course of your workup, this probably represents the most common scenario. It may be that the operation caused it. It might be that it was pre-existing and the operation uncovered it, or it could be some combination of both. In that circumstance, it's reasonable to begin the patient on a trial of PPIs. That might be a reasonable bridge if the patient is still losing weight. And the question is going to be whether or not that reflux will persist with more weight loss. The other question is going to be whether or not PPIs are going to be an acceptable long-term solution. Given all the press and the lawsuits regarding PPIs these days, patients may not be enthusiastic about long-term use of PPIs, but it is a place to start. If PPIs are not feasible, or if they're not desirable for whatever reason, the choice is going to be either conversion to a Roux-en-Y, or, which is generally the most common choice, as opposed to doing something to try to rescue the sleeve by somehow addressing the reflux and leaving the sleeve gastrectomy in place. It's perhaps worth noting that it's reasonable to start by asking the question, should this sleeve be rescued? You have to assess the likelihood of successful GERD resolution, and you need to take into account other comorbidities for which a bypass might represent a better choice. If you decide to convert to a Roux-en-Y, this is the most common approach to definitive management of intractable GERD in post-sleeve patients. It's generally not an excessively complicated conversion. It resolves symptomatic reflux in a very high percentage of patients. Roux-en-Y may be more effective in resolving metabolic comorbidities, and it may be more effective in sustained weight loss. But if the patient doesn't want a gastric bypass, and now you've entered into kind of tenuous territory. The data is thin, the case reports are few, and the patient numbers are small. Most of the alternatives to Roux-en-Y as a treatment for post-sleeve reflux are not terribly well studied, and there's a tendency for these to fit into the niche category. Nevertheless, it's wise to keep these particular clubs in your bag. How do you restore the reflux barrier after sleeve gastrectomy? Well, it's important to have manometric data, and you also need to evaluate meticulously for hiatus hernia. Post-sleeve reflux is multifactorial. In some cases, it pre-existed. In some cases, it was caused by the sleeve gastrectomy, and in some cases, it was merely uncovered by the sleeve gastrectomy. You need a comprehensive esophageal workup in order to make those determinations. You also need to understand that the hiatus is contributed to largely by the lower esophageal sphincter as well as the diaphragmatic crura. A hiatus hernia, if present, that would need to be fixed. It's unlikely to be successful by itself without augmenting the lower esophageal sphincter somehow. Otherwise, your choices are relatively few and far between. There is the Stretta procedure, magnetic sphincter augmentation, and the modified Hill repair. These are, today, the most commonly applied non-conversion rescue techniques for reflux after sleeve gastrectomy. Stretta is an attractive concept because it's pretty simple and it's an endoscopic procedure. It's had a kind of a checkered history over the last 20 years, and the perception of its efficacy has waxed and waned over that period of time. Currently, it's still a little bit controversial in terms of its ability to actually reduce acid exposure, but it is something that can be tried. It does have the recommendation of SAGES as a recommended technology at the 2013 annual meeting. Magnetic sphincter augmentation is also a possibility. There are several small series case reports with generally good results with the off-label use of magnetic sphincter augmentation, the so-called LINX device, as a means of augmenting the LES towards restoring the reflux barrier after sleeve gastrectomy. There is a 30-patient manufacturer-sponsored study ongoing right now that will complete in 2021 that addresses that question. One additional method that can be tried to restore the reflux barrier after sleeve gastrectomy is a modified Hill repair. This was reported by Guerin and has had some success in a small case series. It's generated a lot of enthusiasm on the part of some prominent bariatric surgeons around the country. Basically, what this involves is mobilization of the esophagus, a posterior curl closure, and then fixation of the seromuscular layer of the EGJ to the median arcuate ligament. I want to talk for a minute about reflux and weight gain. This is not a prominent feature of this talk. If there has been weight regain, it does not bode well for the durability of any hiatal repair. Mainly as due to higher intra-abdominal pressures. The higher intragastric pressures that also develop from obesity can overcome any attempt at restoration of the reflux barrier. Conversion to Roux-en-Y, on the other hand, may provide additional weight loss, and it may provide better management of the metabolic comorbidities. In other words, conversion to Roux-en-Y is recommended for patients with post-sleeve gastrectomy reflux and weight regain. I want to finish up by addressing the concept that an ounce of prevention may be worth a pound of cure. We, of course, need to recognize that GERD is common in the bariatric population. We need to pay close attention preoperatively to symptoms of existing reflux, but historical information may not be enough. Only about 40% of GERD patients actually have heartburn as their primary symptom. It's not just about heartburn, and the patient may not recognize that the symptoms that they've been experiencing are actually reflux. I would encourage a very low threshold for pre-op EGD and pH testing and manometry in patients with a preference for sleeve gastrectomy. I think everyone that does this operation consider comprehensive esophageal workup preoperatively in every sleeve gastrectomy patient candidate. Relative to the operative technique standpoint, we should always carefully inspect the hiatus for a hernia, and if it's found, we need to fix it. The last staple firing, we need to stay off of the esophagus to try to avoid the angle of hiss in the sling fibers. We need to be careful about our posterior dissection of the fundus, particularly up close to the hiatus, and we need to try to avoid retained gastric fundus and a hidden hiatus hernia. We need to beware of the incisura because of narrowing, and that's a major source of stricture formation, which in turn is a major cause of the high intragastric pressures that can cause reflux disease. And we need to watch for inappropriate rotation, twisting that is, when doing the stapling, and keep the greater curvature pretty much lined up as we complete that task. That concludes my presentation. I want to thank you for your attention. I want to thank SAGES for the invitation to speak here. These are my references. Thank you very much.